Hello, warriors and supporters. Welcome back. Thanks for joining us again for another great episode of CWF Presents CRPS/RSD is Real. Today we have world-renowned researcher, founder and chairman of American Society for Post-Surgical Pain, and medical director for Tampa PainMD, Dr. Arun Kalava. So without any further ado, enjoy episode 13.
Hello and welcome. My name is Kimberly Sigelka. I'm a CRPS warrior and lead operations assistant with the CRPS Warriors Foundation. I think I'd like to start at the beginning of how you first heard about CRPS and then started treating it at your facility.
Okay, so I think the word CRPS gets introduced to most doctors when they're in their medical school.
Okay.
It is a term that we are very well aware, but also our very little exposure will be there, during your medical school years. And depending on where you end up, I mean, if you go into physical medicine, rehabilitation, orthopedics, surgery, or pain management, then you start hearing a little more of it. And during your training, you might not see some of these patients with complex regional pain syndrome. But one thing is for sure, every examination that you're going to take in medical school or for residency or for your board certification, there is plenty of questions on CRPS as to what the current evidence is. So even before you see a patient, you know a lot about it, but you never encounter them because there are not many, depending on what kind of practice or training facility you're in. So there are some specialized centers, or it's a hit and miss. You might see one or two a year, but you don't see the bad ones. Sometimes you only see minor ones. Sometimes you see a really bad one. So that's how my introduction was. It was a gradual introduction from time you're in medical school down to practicing, training, and practicing now. Yeah, so I see more now because once you start treating more, then you attract more.
Right.
Yes.
And as a pain treatment doctor, I think it's wonderful that you're able to have all these different, I'm looking at your website and you have all kinds of different ways that you seem to help people with CRPS manage their pain. So there's a lot of them that I've seen or heard of before, and there's a lot that I've never heard of before. So I'm interested to kind of talk to you about, so if someone comes into your office, what is your diagnostic procedure in knowing that they have CRPS?
I think half of the patients who come to my office already have a diagnosis of CRPS, maybe more than half. And then a third of them or up to half of them don't have a diagnosis of CRPS. And the onus falls on me to actually diagnose the CRPS in them. Most patients who we diagnose never heard of that word CRPS either. They've been to multiple physicians, and I said, listen, we don't have a test to diagnose CRPS. It is a clinical diagnosis. So we're going to go with the Budapest criteria, which all know about, saying, okay, let's sit down and then go through these Budapest criteria and see if you meet the criteria as set by the experts who came together at Budapest to come up with the criteria. So once they meet the criteria, or some people are at borderline, they almost meet, but they might be missing one criteria. I say, listen, we will treat this assuming that it's CRPS because I would rather treat you in those lines than not treat you. But if you're way off, you just don't meet most of the criterion, then we will say, listen, this is probably a simple neuralgia or post-surgical pain or a trauma-related pain without evidence of CRPS. Obviously, as we all know, it's a clinical diagnosis. There is no test to say somebody has or somebody does not have. Does that answer your question, Kim?
Yeah. And I saw a diagnostic nerve block that's ultrasound guided on your website. And I was curious what that was, because that was not, I just got diagnosed with the Budapest method. And then I had my MRI showed bone marrow edema, and that's how they diagnosed me. So I was curious of what the diagnostic nerve block was.
So coming to the diagnostic nerve block. Now, again, what is a nerve block? Nerves sense pain in the body. We all know that, right? We are trying to put a medicine, usually similar to lidocaine, to numb or to interrupt the pain signals from being sensed by the spinal cord and the brain itself. So we are using an ultrasound to find these nerves, because ultrasound is one which can be, it's a small machine, it's handheld, can be in an office. Usually X-rays show bone in the body. MRIs and CT scans are bigger machines. We can use CT scans and MRIs to do nerve blocks. We can also do them, just anatomical approach. But the most precise approach is to see a nerve that you're targeting to do a nerve block. Now, when would I use a nerve block, right? Let's say a patient comes in like, Doc, I have whole body CRPS. Probably not a candidate. Let's say somebody says, listen, my hand hurts, only my thumb hurts. Or like, okay, my foot hurts, Doc, or the entire leg hurts. I'm going to say, okay, Mr. X or Mrs. X, let's take a look at the anatomy. What is the nerve supplied to the area of your pain? I usually tell them, an analogy saying, okay, our spinal cord is like a tree trunk. And there's all these branches, which are the nerves that come out to different, arms, legs. Then we'll zone into the area of pain. Okay, if somebody says, I have foot pain, I will say, is the foot pain on the top of the foot or the bottom of the foot? Because the top of the foot is a different nerve, bottom of the foot is a different nerve. Depending on the nerve innervation, we would go ahead and do a nerve block to see if that nerve block might give them either temporary or more long-term relief. Again, I don't use the word permanent because it's more a chronic disease. Obviously, it's a complex and a chronic disease. Just like high blood pressure and diabetes, you might have to manage it all your life. And if you're lucky, you might get better, really quickly, and then you're back to normal. So I usually, set an expectation saying, listen, this is something like high blood pressure, diabetes, you might have to continue doing. So the reason why we do is to confirm that this is the nerve that is actually, sensing most of the pain, or is it inflamed or irritated, to numb it, which can give us a temporary relief. We also put a little cortisone next to it to see if that might reduce any inflammation around the nerve, which can constantly cause nerve signals to be firing and causing the pain. So I think it has a multitude of reasons why we would do that. One could be diagnostic, the other could be therapeutic. As I said, putting steroid. And also it gives us a map, like what do we do next? It will be a starting point. But again, I would only do that if patients have failed other modalities. When I say other modalities, it could be non-invasive treatments, medications, physical therapy, occupational therapy before I start the nerve blocks.
Okay. So the things that I'm going to be talking about are probably on the same level, that you're starting with medication, physical therapy, like you said, other modalities first, then you'd go into nerve blocks. And then there were things like peripheral nerve stimulation, continuous nerve catheters. I don't know what that is at all. So right. I'd like to know more about that.
I want to touch base on, the non-invasive treatments and the medications briefly before we go into the more invasive options. Now, non-invasive options, everybody knows about physical therapy, right? That's just common knowledge, occupational therapy, patients. When it comes to non-invasive options, there's two options which are not mentioned to most patients. One is laser therapy. Now, laser has been there for many decades. Laser is used for, hair removal, eye surgery, tattoo removal lately. But there is a class 4 laser which is specific for pain management. So the wavelengths and frequencies are set in a way it reduces inflammation. So if I were to have CRPS in the first, I haven't been diagnosed or not diagnosed, but I have this acute pain, I'm going to start with a non-invasive option, which is not even pills, localized laser therapy. That's one. Number two is cryotherapy. Now, people know about these cryo chambers. They go jump into the chambers and it's extremely cold. Now, what cryo does, we have a cryo gun which is localized. So we actually, let's say somebody comes in with foot pain. I don't have to ask them to go into a chamber. I would say, we're going to use cold to slow the nerve conduction, reduce edema or swelling. Because what cold does, like everybody has surgery, what they would do is, put an ice pack on, do icing 3 times a day for the next few weeks. Guess what? The ice cools the skin, but it doesn't go all the way down to the tissues. It might take a long time. What we do with the cryotherapy is we use high pressure, low temperatures, close to about minus 80 degrees Celsius to cool. So if you look at these videos that we have online on some of on our website, you can see how this cryotherapy is done. It's literally carbon dioxide cold, which is ice, air, being targeted to this tissue or the area of pain. Now, remember, just like physical therapy, one treatment doesn't give you any relief. It has to be at least 5 to 10 treatments before you see any tangible relief. Let's say I get 30% relief out of either cryo on laser or cryo or laser. Some people don't like cold. It's like, I can't tolerate this. I said, let's just do, laser is a little warmer therapy. So we'll do that. Now, when it comes to medication, I think a lot of people know different medications. So I don't want to dwell too much on it, except for a few things I want to touch base on when it comes to medication. Medications are systemic therapy. Every inch of your body gets affected, right? There is new data coming out, which is very promising with type 1 CRPS. Now, type 1 is when we don't know which nerve is involved, correct? Type 2 is when you specifically know a nerve. Like if I do a nerve block, I know it's most likely type 2. Type 1, 90% of the patients with CRPS will have type 1. Type 2 is uncommon. Prednisone over a month. So if you do a prednisone taper of 40 to 60 milligrams, just like people do Medrol dose pack, right? They have asthma, they have some bronchitis, they will do a week of taper. No, for CRPS, the current recommendations are to do a 4-week taper, 40 milligrams 1 week, 30 milligrams a week, 20 milligrams a week, and then 10 milligrams a week and stop. The data is so promising in Canada. They looked at hundreds of patients. I think the response rate is 70% will have complete remission of these symptoms. Just one prednisone for 1 month. It's really groundbreaking, to be honest. So I routinely start these patients on, okay, let's just start you on prednisone, which is very simple, before we dwell into much, invasive options. So you have non-invasive options, no medications, laser and cryo. Medications wise, start with prednisone, and then maybe look into your gabapentin, Lyrica, all those things, because they do take time to give you some relief. The other thing is using ketamine oral pills. I know people talk about IV ketamine, but very few people talk about oral ketamine. Ketamine is available as an oral therapy, which is less expensive than intravenous therapy. Okay. So I would say, let's start you on some oral ketamine, laser cryotherapy, prednisone, go home. Come back, see me in 4 weeks, see how things are. At least if it didn't work, then we have a reason to start doing invasive procedures, which would start most likely with a nerve block. But if somebody says, I've done all these things, then we'll just start with the invasive procedures. Now, coming to your question about the options of nerve catheters, right? So there's a few studies out there and case reports wherein, just like we do nerve block, on top of doing a nerve block, we'll put a little catheter right next to the nerve and continuously drip numbing medicine for days, usually a week to 2 days, 2 weeks. So they would go home with a ball of local anesthetic. So recently, government, Medicare has already, there is a No Pain Act, which recommends use of these on-cue pumps or a nerve catheter pump of local anesthetic that goes home with the patient, just like an IV. It's like an IV is intravenous. It goes into the vein, right? We're perineural, like around the nerve of the targeted nerve. Let's say the entire arm is CRPS. I'll put a brachial plexus, which is the nerve bundle that senses pain in the entire arm. I'll put a brachial plexus nerve catheter, send it home so we continuously stop this pain. And maybe once we take it out, maybe the pain will just either significantly decrease or disappear.
Wow. How long does somebody have that on
so usually it's 7 days. So anything more than 7 days, the risk of infection increases. So we want to replace that catheter 7 days later. Also, the balls of medicine usually last about 2 to 3 days. So we send them home with about 1 or 2 more extra balls of local anesthetic, which they can simply switch themselves. And there's always a 24-hour support for these, a nurse is available should they have a problem with the leaking nerve catheter or anything like that. Again, those are usually done in a hospital setting, but in our office, we can do in our office setting. That's one thing. When it comes to other options, cryo-neurolysis, what is cryo-neurolysis?
Yeah.
We just talked about cryotherapy, right? Cryotherapy is using cold air from the skin, high pressure going down to the nerve and to the tissue per se. So it's taking out the swelling. Same thing, cryo-neurolysis. I will do a diagnostic saying, okay, I'll give you an example. One person comes in, they have clinical signs of CRPS. their foot hurts just on the top, nothing on the bottom. It's red. They had a foot surgery, really hurts. I'll say, well, this is a superficial peroneal nerve. That's a branch of the sciatic nerve, again, which is a branch of the spinal cord, which is the tree trunk. So the tree trunk has a bigger branch, then a smaller branch. So I'm targeting the most peripheral stuff. So I'll say, okay, you probably have superficial peroneal neuropathy or nerve involved in the CRPS. Let me numb this. They say, oh, I got 50, 80% relief, but only lasted a day or two. Then be like, okay, well, this is a nerve which is primarily sensory, very little to no motor function. I can use a needle with a freezing tip of ice ball, which can freeze the nerve to minus 88 degrees Celsius, which is about 140 Fahrenheit. Again, they're usually done when the patients are breathing nitrous oxide, which is laughing gas, or under their anesthesia. What we also can do it when patients are awake, because I can numb the nerve, then freeze it. So most people are just like awake. I'm like, what's happening, doc? I said, well, I just need about 10 to 15 minutes to freeze this. So just lay down and get it done. So it's very specific, targeted for nerves like those. And we had tremendous response that people get 100% relief when the nerve connects. So the nerve is being frozen at that level where we're freezing. And what it does is cause a reversible nerve injury. Nerve injuries are classified, into 4 different nerve injuries. This is class 2, wherein it's reversible. So the nerve will regenerate completely. Just like our hair we cut or nails we cut, they come back and grow. When we do a cryotherapy, cryo-neurolysis, the nerves regrow. So the new nerve might sense the pain as it was before, or it might sense a little less, or it might sense none. So the duration of pain relief is usually 90 days. This is FDA approved for all peripheral nerves.
Okay. So if someone has type 1, it doesn't matter that you don't know what exact nerve it is because you're using that area of the peripheral nervous system. That's what you're targeting. It doesn't matter that they don't know the specific nerve that was damaged.
Correct. So, the diagnosis at the end is just for us to play around saying 1 or 2. At that time, we say, listen, if somebody gets great relief, I said, hey, we'll just change your diagnosis to type 2. It doesn't matter for the patient. Is it type 1 or type 2? It's better to just figure out and say, okay, you come in with these localized symptoms. Again, it has to be localized symptoms which can be targeted, like the smaller nerves. Bigger motor nerves are amenable to cryo-neurolysis, but most of the time it's sensory nerves. So if it's a motor nerve, I'm giving the same example. Patient has top of the foot, bottom of the foot, around the ankle, the entire sciatic nerve, the whole leg is involved. So I would say sciatic nerve is the biggest nerve in the body. It's about 2 centimeters. I cannot freeze a nerve because it has motor function. In that case, I would choose nerve stimulation, which is peripheral nerve stimulation. You would say, so what's the difference between peripheral nerve stimulation and spinal cord stimulation, or DRG, which a lot of people do end up getting recommended? Same thing, the analogy goes back to the tree trunk. Your spinal cord is the tree trunk. If my problem is one of the peripheral branches, why am I stimulating the whole trunk? I would rather do the electrical stimulation at the peripheral branch, which is causing all the pain and disability. So peripheral nerve stimulation has been pretty good in our practice, wherein we like the other day we had a patient with hand pain after having an IV placed for a surgery. Her thing was her radial nerve, which senses the top of the hand, got involved. We did a stellar ganglion block, did not give her relief. We did 3 nerve blocks of the radial nerve with steroid, did not give her relief. Then we tried, obviously, this prednisone, which I came to know a few months ago. She actually had more side effects and it did not help. So we said, we tried everything we can. I cannot freeze this nerve. It's a radial nerve, which is required for your hand function. We should do peripheral nerve stimulation. So we did a peripheral nerve stimulation. She's now able to she's right-handed. She's now able to hold her mouth. She's able to gainfully get an employment. She's back to near normal. It takes a few months, but that was her algorithm. Again, everybody's so specific and different. Yeah. We tried all these smaller interventions before I'm placing an implant because it's a more permanent, more long-term solution to it. But I believe in targeting the peripheries if the periphery is an issue, like much more further down to the branches versus taking the trunk and putting an implant in the spine. You know what I mean? Like the DRG or dorsal root ganglion or the spinal cord stimulators. A lot of the pain physicians are trained in doing those. My training is more in the peripheries, so I tend to focus more in the peripheries. So options are there, but I think everybody has an individual plan. It can be cookie cutter, but there are more options than they were 5 years ago, honestly.
It sure seems like it. I'm learning new things every time I talk to somebody. It's pretty amazing. I'm really grateful that I've been able to do the podcast because I get to talk to people like you who I couldn't talk to otherwise.
It's good. I mean, they're very promising. So I'm very excited about these options to offer and how I see those results. Yeah.
Yeah.
So when we're talking about nerve stimulation, I think I've heard of different devices, ones that are on the skin surface, more like a TENS unit, ones that are implants. So are those, they're doing the same thing, but different levels?
Correct. Good question. So nerve stimulation uses the same technology, whether it's percutaneous under the skin or transcutaneous, which is TENS unit or spinal cord stimulation. The technology is the same. What it does is when you're sending electrical stimulus, it interrupts the pain signals wherever you're sending them. So the spinal cord does not sense those signals. If you're getting good relief with that, a peripheral nerve stimulation would give you, it's like this TENS unit on steroids. So I'm getting it right on the nerve. Could be on the sciatic nerve. Sciatic nerve sticks, so we usually use 2 stimulators instead of 1 because it's such a big nerve, which might give you much more. But again, who wants an implant? Like I personally don't want an implant unless I really need it.
And then you talked about oral ketamine at the beginning, but you also do intravenous ketamine, correct?
Yes.
Okay. What do you think is it just the IV ketamine is just like a more intense version of the oral, or is it different?
So ketamine, as you know, is an anesthetic. At sub-anesthetic doses, a microdosing of ketamine provides pain relief. Now, a lot of people don't know there's multiple forms of ketamine. There is an IV form, there's an oral form, there's a rectal form, and there's a nasal form. So there is a lot of, the oral form is easy to use because you're at home taking it every day, and that's helpful. And it's also a little less inexpensive than an IV form. Now, what's the difference between oral and IV? IV is 5 times stronger. It depends on the severity of the disease, right? And how bad it is and how bad the patient is. So if somebody's got mild to moderate symptoms, I said, you know what, sir, you should go on oral ketamine as a trial as well. Like, is this helping me a little bit? Then maybe I should go for IV ketamine, because once you get started on the infusion series, it's a very long, arduous infusion series, you know? So for that reason, I would say start on oral ketamine, see how you feel. I'm bridging you until I figure out what to do with you particularly. So I'm going to give you, so we don't get started. We'll do a nerve block today, take the oral ketamine, see how it goes, come back. We'll do the cryo-neurolysis if that's the case for you, or a nerve stimulation. Until then, you have something to take. And a lot of the times, as we all know, ketamine is great for your CRPS, and they all respond. They at least don't have severe pain. They may have mild to moderate pain, until we have more definitive, more effective pain management options. So it's been very helpful in my practice. So most people will be on ketamine orally until I figure things out for them. Once they're better off, I said, we need to stop the ketamine, just come back when you have pain or, any issues.
Okay. And then I think the one that we didn't cover yet would be the radio frequency ablation.
Mm-hmm. Good question. So radio frequency ablation has been there for decades, and it's used, again, when it comes to cryo-neurolysis, it's freezing. Radio frequency is thermal hot. We're heating the needle versus cooling the needle. So two different things. Radio frequency is not applicable in case of CRPS in my practice, as it causes more of a damage to the nerve, which is not reversible a lot of times. It can be reversible. Also, it's not applicable to any motor nerves. Let's say the same nerve I have on top of the foot, I could freeze, but I would not recommend doing the radio frequency ablation because it can actually make things worse.
Okay.
The foot is hot, right? Do you want to make it hotter? No. So we want to cool it down. So that's why we use freezing. So just a layman words would be like, I wouldn't use radio frequency ablation if I have CRPS. I'm always going to go for cryo-neurolysis or peripheral nerve stimulation. Radio frequency ablation is just something I just don't feel comfortable, or I feel the risks outweigh the benefits in CRPS patients.
Okay, good to know. It's really interesting that you use so much cold therapy, because I think one of the first things, like ice and my foot just don't get along.
Exactly.
Like when
So
it's cold
again,
outside and all that kind of stuff.
so
it's
for
like,
them, we don't recommend cold. Some people like the cold, and
okay.
but cryo-neurolysis has nothing to do whether somebody has liking to cold or not, because I'm going deeper, numbing the nerve, and then taking effect, because that's just. But I wouldn't do the cryotherapy, which is outside cold, because they don't like it. It's just probably not going to help them, or they're just going to be suffering through the treatment.
Okay.
Yes.
So it just depends on because we're all so different of how we react to things. So it just depends
Correct.
on the patient, on how sensitive they are to different things.
Right. So, I mean, implant is always an option, but it's usually the last option, to be honest. So, like, okay, I don't want to leave an implant. We should try something. If they're like, I just don't want to do cryo-neurolysis. I'm like, okay, then let's just do implant, because you just and most people do not like cold with CRPS. Cold is not a friend for them.
Yeah. That's how I describe it most of the time. It's just not my friend. So it seems like it's if you have the peripheral, if it's a peripheral nerve affected, like the CRPS is coming from peripheral nerves, you have a lot of options of things to try, possibly more than you do if it is something that is more like involves
Generalized
motor function, right? So that has more like less. If the nerves are not peripheral, there's less options.
Yes, if the nerves, let's say, but a lot of the times CRPS is in the extremities. You see fewer and fewer patients who have whole body CRPS. In that case, you have to treat the whole body. So you're going to look into intravenous ketamine, oral medications. You just target the most severe part of the CRPS, the body part. But motor or non-motor, I think both options are pretty amenable in the peripheries. Okay. A bigger sciatic nerve, brachial plexus. I mean, I've had patients who had all kinds of things that I just talked about. They could stop anywhere, or they might go all the way down to peripheral nerve stimulation. Just like the lady I just talked about having a CRPS after IV placement. Surgery is still an option at the end if nothing works or there is nerve damage. But if you're able to get 50 to 70% relief and they're able to carry on with their life, I mean, that's basically where we stop.
Yeah, it's huge, bringing that pain level down by 50 or 60%. It's amazing how much more life you have when you're able to think about things other than your pain. So that's fantastic. I saw that you're doing all these things to try and avoid possible need of spine stimulators, or
correct.
What are these pumps that it mentions?
Intrathecal pump.
Yeah.
So these are intrathecal pumps are, you actually put opioids or morphine and other toxins into the spinal column wherein the spinal fluid is. It's an FDA-approved treatment for chronic pain which doesn't respond to other modalities. Let's say we failed spinal cord stimulation, peripheral nerve stimulation, cryo-neurolysis, everything's failed, and the patient is in miserable pain, then we recommend them to get an intrathecal pump, which is just a pump which cancer patients get routinely for cancer pain because it's debilitating for them. So it's microdosing of that opioid into the spinal column, or there is a neurotoxin that comes from snail. It's called snail venom, which is also FDA approved to be placed inside the spinal column. So catheters actually go into the spinal column where the spinal fluid is around the spinal cord. The spinal cord stimulators and DRGs are outside the spinal column, outside the covering. They don't go inside. They're just using electricity. The pumps use microdose of morphine, dilaudid, or this called ziconotide.
Okay. So these are like last resort. Very
correct.
invasive.
It is a last resort. I had to send a couple of patients in the last 4 years because we tried everything. Peripheral nerve stimulation, cryo-neurolysis, ketamine, everything we tried, but the patients still had pain. Then I'm like, okay, at this time, nerve release surgery did not help. So then okay, now we need to go get this pump.
Okay. When you mentioned nerve relief surgery, what does that involve?
If we believe that the nerve is being compressed, A lot of times it's either foot and nerves to the foot that can be compressed, causing these nerve symptoms. So if there's scarring from the previous surgery, right, then you try to release the nerve off that compression.
Okay. How do you find out if that is something that's happening? Like if you have a compressed nerve, is there a diagnostic
Yeah,
tool
usually
to
we
find
send them
that?
for electromyography, EMG, or nerve conduction studies, which the physical medicine rehabilitation physicians or a neurologist who's certified in doing these nerve conduction study will give us an idea whether it's being compressed and where it is being compressed. So we have a map for the surgeon to figure out what they have to do.
Okay.
A question I always like to ask is why you decided to become a resource for the foundation.
I think one of the CRPS Foundation members reached out to me, I believe, or the staff reached out to me to see if I'm interested. And then I spoke to Deborah, and then I said, the foundation lines up with what I do. And a lot of times the patients do see multiple physicians. So we're trying not to minimize the number of physicians patients see and have them resources, available so they can go to the right people closest to them and educate them about more options. So, a lot of times they just don't know these options exist, and they're given cookie cutter options of either ketamine or just DRG, spinal cord stimulator, and that's about it. Or the sympathetic blocks like, stellar ganglion block, lumbus sympathetic. They do help in some patients, but a lot of patients, they don't. So I'm trying to see how we can, fast track these patients into, places which are more specialized, have seen more or treated more or have more options, and also are up to date with what's out there versus, not being up to date. So we always try to be, we always look at the evidence or create evidence. Like I always publish saying, okay, these are the cases about CRPS. Here's a publication, a case series, and what our experience has been and how impressive these results have been. So, those are the reasons. I mean, I think you're connecting the people around the world, and I'm just educating everybody that there are more resources and there is hope. So we're trying to keep the hope alive, because a lot of the time it's just, that's what you need, some hope.
Yeah. Thank you so much. We really appreciate it. I was really excited to learn about new things. It seems that every time we talk to a new resource, we're learning about new ways that people are helping. And I think there are a lot of people that are disconnected from a doctor that really knows what they're talking about with CRPS. So if we can get them connected to you and hear that there are options and people out there that know what they're talking about and can give you a little hope, maybe a little bit of relief from the pain that you're in, then that is so important. Is there anything that we didn't talk about that you want to share with the CRPS community?
Yes, I think, people think it's a curse at times, that why me, and, and how bad it is. But I think if you find the right providers who know what they're doing and who help, and you find resources like, as you said, your foundation, who can both, give them support emotionally and times financially as well, is a blessing. You just have to, deal with the situation, just like in life, things happen. We just have to say, what do I do? I got this situation. How do I resolve this? How do I deal with it? And I think the positive attitude is very important in these patients, and not get depressed and, bogged down. You just say, listen, there is hope. There is treatment available. What would be the best thing? Let me be open to having conversations with a few physicians. It might be very draining to be talking about the same thing to multiple physicians, but you have to make up your mind, like, listen, it's for my own good. I have to find the best treatment available, best physicians, best providers who treat these, and have the hope that, it is a bad disease, but there is a lot of hope as treatments evolve, and we're getting better. It's a science that keeps evolving. I think it's only going to keep evolving, and more patients will get, more treatment options than what we had 10, 15, 20 years ago.
That's great. Thank you. We really appreciate it. I'm very excited about hearing more. Like you said, the study with the prednisone, I think that's amazing. I don't know how, you said, I think it just came out not that long ago, right?
Let me just see. I can send you the link. So you actually can put it on the website, maybe a good resource, because a prednisone prescription can be done by any primary care physician or, even a PA nurse practitioner. a simple thing might just fix it. And if you look at the results, it's amazing how many people got relief, like complete resolution of their symptoms. They even have pictures from before and after. So maybe you can put like, hey, prednisone seems promising. It's not a bad thing to try.
Wonderful. Because my doctor's office had put me on a prednisone pack, but it was only for a week.
Correct. So those are very low. You're 24 milligrams, then 20, then it goes down to 4. Here you're talking 40 to 60 milligrams for a week, 30, 20, 10. It's amazing the people's response. And I have a patient who responded really well with the sciatic. Her entire leg from buttock down was involved, and she had about 50% relief. Then we did a couple of nerve blocks. She got better. She's able to walk, wiggle her toes, simple things in life. I mean, like, wow. If you open it up and then it shows at page 6, prednisone, outcome of initial treatment, completely resolved, completely resolved, completely resolved, mostly resolved, mostly resolved, I mean, it's amazing. Wow. It's just for all upper extremity, lower extremity, mostly. I mean, mostly and completely is a word which is unheard of.
Yeah, that's not normally a word associated with CRPS.
If you look at the promise, I was like, listen, it doesn't hurt you. It's only a month. I mean,
yeah.
It's mind-boggling. This came out about 9 months ago. It's just like, wow, man. I mean, so everybody in Canada is getting this.
This is fantastic.
Yeah, talk about it or go through all the suffering and multiple physicians. Just get a prednisone prescription and you might be fixed. No, I mean, it's true. It's a
good way to
start. Somebody has to try it. Somebody tried it and it just seems very promising to me.
Yeah, that's fantastic.
Yes.
I think a question I had is, this is just like randomly came to me when you were talking about oral ketamine, and then if someone's on gabapentin too, are these things that can be overlapped, or is that like you're on ketamine and not on gabapentin?
No, I think ketamine is a very safe drug in our practice, where you overlap with pretty much any drug. You just have to be careful with patients who have heart disease, because ketamine does increase heart rate and blood pressure. Otherwise, most of the time it's safe. The interaction is minimal to none. It can be used in combination, but the only thing I always make patients aware and be cautious is gabapentin, Lyrica, amitriptyline. All these medications make you sleepy. So does ketamine. So you're adding a lot of these sleepy medicine. You might be very sleepy and might be feeling very tired. The other drug I don't know if people mention, is low dose naltrexone. I'm sure people know about low dose naltrexone. Yeah. Yep. So that's something to consider. I mean, you can combine ketamine with low dose naltrexone. You can combine, low dose naltrexone with gabapentin, Lyrica, all those things. So simple drugs might just take care of the problem and not worry about more invasive options. Should they not, then the other options do exist.
Trying to think if there's any other questions that should ask.
I think we covered most of it. What I wanted to cover, make sure the prednisone message goes across, the oral ketamine message goes across, use of laser goes across, use of freezing the nerve, which is really new. Like they used to freeze many years ago, but the technology hasn't evolved to the point where now we have handheld devices. Things are done in the office. Patients are awake. It's becoming, very easy to perform as long as you have skills with the ultrasound. As the ultrasound skills evolve, we can target more of the peripheral nerves. Yeah, but those are the main things. So things that usually people don't even know exist.
Yeah, those were new things to me and sound really promising. And thank you for sharing them with us. And if you come across, like you said, you're looking at studies. So if you come across something that you want to share with us, please let us know, and we'd be happy to do another podcast about it. So
absolutely, I think that's very impressive. For now, I think prednisone is a thing to remember. Cryo-neurolysis is a new thing to remember. Oral ketamine and nerve stimulation, peripheral nerve stimulation, stopping getting the spinal cord, because half of the time they don't work and they come back getting peripheral nerve stimulation in my office. So you go through the whole process. Insurances do not cover, and that way, like, you would have just done a peripheral stim and then you'd be fine. But it's okay. We're just trying to educate so people don't, take a misstep or an uninformed decision. You should have an informed decision made with all the options available before you take the plunge.
Absolutely. Thank you so much for sharing your knowledge and helping to educate people.
What do you do? You're spending all this time and resources of your own voluntarily. So I appreciate you guys, what you do.
Thank you. It was really a pleasure to meet you.
Pleasure to meet you as well. .
Thank you so much for taking the time out of your busy day to sit with us to discuss so many options. If anybody out there would like to get in touch with Dr. Kalava and his practice, his contact information is in the description of this episode, as well as the link for the prednisone study in which he mentioned. Also, the founder of the American Society for Post-Surgical Pain, Dr. Kalava is hosting their first conference this September in Tampa, Florida. Our next support group is August 21st. If you haven't signed up yet, registration is still open and you still have time. At this group, special guest attorney Geraldine Lee is going to pop in and answer some questions about workers' comp cases. If you would like to support the foundation in the podcast, please text CWF podcast to 53555. We are still in need of silent auction items for our Rockfest Hay Day event coming up in September. If you have an item that you would like to donate, please let us know at info@crpswarriorsfoundation.org. As always, it's been a pleasure, and we look forward to the next time. So join us back on the 1st. We'll be back with a whole new episode of CWF Presents CRPS/RSD is Real.